Physician-assisted suicide.
Physician-assisted dying.
Euthanasia.
Clinician-assisted dying.
As of 2026, 1 in 3 Americans live in a state where a physician can legally write a prescription that can help someone die. When 10 years ago, that number was only 1 in 5. Yet still, less than 1% of deaths in the United States.
What do you think is the premise behind the self-administration as opposed to a nurse, a medical aid, someone from hospice, right? If a patient's on hospice. So what do you see as the premise behind that? Because I can imagine of a few, including very much centered on legal issues. But
with the express goal to hasten death, whereas with medical aid in dying, they are looking at very specific patient populations, patients with very serious and terminal illnesses, typically less than 6 months.
Important question. Do you think it should, let's say legal aside, let's say everything's legal. Do you think that's appropriate? And are there situations that you think that it should be able to be administered? I have an answer, but I'm curious about yours.
Yeah, I think, the challenge here, and that there's always kind of this false dichotomy, I do feel like, where we have to be 100% in the yes, it's always appropriate in every situation, or no, it's never appropriate at all times. And I think a lot of us kind of live in that gray space in between. There's kind of this moral pluralism. And I do want to make sure that always I'm approaching each situation with a sense of kind of curious humility to really understand what's happening for that particular patient and their family going through this.
As of 2026, 1 in 3 Americans live in a state where a physician can legally write a prescription that can help someone die. When 10 years ago, that number was only 1 in 5. Yet still, less than 1% of deaths in the United States are related to medical assistance in dying. We're joined today by Dr. Joseph McCollum, who is a medical oncologist and palliative care physician from Fort Wayne, Indiana. Thanks for joining us, Joe.
Glad to be with you guys.
Hey, Joe.
So, medical aid in dying. I remember the first time I heard this. It was a patient of mine who had just been diagnosed with metastatic pancreatic cancer, and it was our first visit. And on that visit, that patient made it very clear that they were willing to do the treatments, but when the treatments stop working, they're going to move to a different state because they are interested in quote unquote physician-assisted suicide, and they wanted to move to a different state and get that. And nowadays, we're seeing increasingly that there are laws being passed in multiple states allowing for medical aid in dying. So, Joe, what is the biggest myth around medical aid in dying in the United States?
I think the biggest myth surrounding medical aid in dying is that it is equivalent to euthanasia. So I think there's a really important factor between the two. So euthanasia is an active treatment where the physician themselves are administering this therapy with the express goal to hasten death. Whereas with medical aid in dying, they are looking at very specific patient populations, patients with very serious and terminal illnesses, typically less than 6 months to live, who also have a extensive amount of suffering that they're going through. And then the physician would be prescribing the medication but not administering it. This is something that in a majority of states in which MAID has been made legal, the patient has to self-administer the medications.
Let's insert. What do you think is the premise behind the self-administration as opposed to a nurse, a medical aid, someone from hospice, right? If a patient's on hospice. So what do you see as the premise behind that? Because I can imagine of a few, including very much centered on legal issues. But
yeah, I think the legal is probably one of the biggest core pieces, right? And so if there is another individual who is administering the medication, then it's very difficult to imply that the patient was able to do that from their own personal volition. And then we have one human being intentionally causing death to another human being, and no way of verifying whether that was a consenting process. And so if it is a self-administration, then you have that individual who's incurring harm upon themselves, not involving necessarily another individual unless indirectly.
Important question. Do you think it should, let's say, legal aside, let's say there's everything's legal. I don't, you get what I'm saying. Do you think that's appropriate? And are there situations that you think that it should be able to be administered? I have an answer, but I'm curious about yours.
Yeah, I think, the challenge here, and that there's always kind of this false dichotomy, I do feel like, where we have to be 100% in the yes, it's always appropriate in every situation, or no, it's never appropriate at all times. And I think a lot of us kind of live in that gray space in between. There's kind of this moral pluralism. And I do want to make sure that always I'm approaching each situation with a sense of kind of curious humility to really understand what's happening for that particular patient and their family going through this. But I think that there is a limitation as a palliative care specialist to what amount of suffering we can see, right? I think it'd be hubris to say, as a palliative care specialist, there is no situation that I can't palliate, that I can't relieve the suffering of somebody with an advanced cancer or another serious medical illness. And so also suffering is intensely intimate and subjective. And so the suffering that I might consider for myself may not be the same suffering that someone else considers for themselves, which is why, even though I feel personally opposed to MAID, I can absolutely see why someone would want to pursue a path to MAID.
I kind of completely hear what you're saying, where you might feel differently and then somebody else might feel differently, and I think that that's a really important part of why I'm hugely pro MAID, is because I think when I was earlier in training, I thought comfort is the absence of pain and symptoms, like, right.
Mhm.
That's what and we can, for the most part, if you are getting good care with a multidisciplinary team and even have like a social worker, and really you're well taken care of, that you won't suffer. And what I've increasingly encountered, I feel like, in practice, is that suffering is deeply personal to people and very different across people, right? It might be loss of independence. It might be the inability to communicate. It might be loss of control of bowel functions, or really any bodily function. And,
Mm.
or it might be that feeling like they are, that their caregivers now have to spend all of their time, energy, effort, money, whatever, what have you. And I think that we already respect patients' right to decline treatment, right? That might
Mhm.
prolong their life. We already make that as, you're allowed to do that, right? Even though we
Mm.
think, like, I'm your oncologist, I think, oh, if you get on FOLFIRINOX, maybe we can give you X more months. Of
Mhm.
course, if you say no, I respect that. And so I feel like we have a responsibility to respect a patient's right to also, you know, not prolong suffering, even when that choice leads to death.
But that's such a big difference from saying that I don't want to seek active cancer therapy, or I don't want to have surgery or even a curative treatment for my disease. For the longest time, the way we've been practicing in the United States prior to the MAID rules is that if somebody has pain and we're looking to palliate the pain, or they have dyspnea and we're looking to palliate the symptoms of dyspnea, if the treatments to palliate those symptoms were to enhance someone's time to death, that was considered acceptable. What we're talking about in MAID is to give medications with the intent to end someone's life. And from my perspective,
Right.
that's a much bigger jump than we're just looking to make someone comfortable. And we're talking about, I think this is where Joe, you were coming from, is that we can completely understand where someone who's going through a chronic illness or terminal illness is coming from. But when we talk about rules and laws, we're talking about societal norms and what we accept as being appropriate in our society. Of course, in the United States, that also means who's going to pay for it, and what implications it could have on your life insurance and your health insurance and family and estate and those bits as well. But the jump from saying that someone can decline chemotherapy, or we palliate someone's pain to comfort, versus we're giving treatment with the intent to aid in death, for me is very, very different. And I'm following this debate online, and some of the conversations are fairly unsettling for me, especially when I see how medical assisted medical aid in dying has evolved in other countries.
Yeah, I have to agree with you, Sean. I think that ultimately, when you omit a therapy for yourself, you're making this conscious decision of, I don't want to suffer the harms of a toxicity for a disease that I didn't ask for. But I think in MAID, you are actively pursuing an end to your life because
Mm,
of either a current suffering that you're going through now, which, if you look at the statistics, it's rarely physical. It's rarely
mhm,
uncontrolled pain or physical symptoms, though it is for some. It's almost always loss of autonomy. It is
mhm,
this sense of, I've lost control. And so I want to gain control. And there are individuals who said, I've had my control restored just by having access to the medication. And there's still about a third to a quarter of patients who never take it and
mhm,
still have a natural course to their life. I think one of the challenges that I have is that suffering is a dynamic process. Right. So when I had my 12th birthday in an orphanage, or even as a teenager growing up in foster care, I had a level of ultimate suffering and I had
mm,
suicidal ideation. And I think if I had a culture that told me that there was a death option, I don't know if I'd be having this podcast with you all right now, because my outlook as a foster kid looked really bleak.
mm,
But I got support, and that support is what helped get me through the suffering that I was experiencing and to a place where now I want to give to others who are suffering and alleviate their suffering the same way that someone did to me. Now, I don't want to equate people who are going through terminal illnesses, especially advanced cancer, to what I went through. I know it's a completely different process. But even all of us as GI oncologists, we've seen patients who thought that a life with an ostomy would be absolutely no life at all, or a life with an amputation would be absolutely no life at all. And then they have those experiences and they realize that they can adapt and still find meaning to their life and purpose despite the challenges that they're facing. And so I think one argument in opposition to MAID is, how do we then address the suffering in more creative ways instead of saying the final option is the only option?
So I love that you bring up meaning. I know I'm very pro MAID, and I'll talk about that a little bit more. But I totally agree with you. I read a book in med school called I think it was Man's Search for Meaning. It was like Viktor Frankl, and it was a man who experiences being a prisoner in a Nazi concentration camp, and he talks about how people can find meaning in the most horrific, obviously what he went through in the most horrific situations. And so I just wanted to say that I actually totally hear what you're saying about that, where I think life is dynamic, right? We know that about life in general. And even when somebody is going through cancer treatment, they have their ups and their downs, and that's just the reality of all situations. But my argument, of course, you knew that I was gonna come with that. But my argument is that we, even though we know that, we don't get to. I don't feel like we get to make that decision for people. Like in the same way that I can know, like the equivalent that I'm trying to make is that what we're saying when we're talking about MAID is that, oh well, we know that maybe suffering is can oscillate, right? There can be ups and downs. Even though I would argue that in advanced cancer, the ups and downs are they're in a narrow spectrum because of the cancer being uncontrolled and all of those things. But there can be ups and downs. And we
Sure.
know that even when we're talking about chemo, though, right? Like I can tell somebody that if you have a lot of we keep going back to pancreatic cancer, but that's just what we're talking about now, right? Where um, so, there's some patients who feel better after we give them chemo because they have
Mhm.
shrinkage of their tumor, so that now they're not in pain, and we've managed their chemo related side effects very well. And I know that, but I don't get to make that decision for them. And the reality is, and that's in part because one, autonomy, but two, because it's possible that their pain gets better, but it's also possible that their pain doesn't get better. And I would argue that's the same thing when we're talking about MAID, right? It's possible that you may feel less suffering over time, but it's also possible that you don't, depending on what is causing your suffering and all of that. And so I don't think that every patient should be on, like, should be offered MAID or necessarily is appropriate for MAID. That's probably what I would say.
Mhm.
But I do think that there is an argument that people have autonomy. And even though we might feel differently that, oh, I really think we could get your suffering under control, we can do this, we can do that. I would argue that I feel that way when I'm giving chemo as well. But I still have to have a risk benefit discussion with people and then respect where they're coming from.
Are we ready for some provocation then? I'm going to follow up on that.
Yeah,
This is
go
for
for
all
it.
of you.
Yeah.
So this is based on what you guys have said so far, right? So palliative care to relieve suffering, right? To alleviate suffering. And so far what we discussed, medical assisted dying as almost like a continuum, right? So initial diagnosis, let's continue with metastatic pancreas cancer, chemotherapy given with palliative intent, right? With stage 4 to relieve suffering, as you said very well, Shruti, pain diminished if the tumor shrinks and so on and so forth. And then graduation to hospice, which by definition, terminal illness, less than 6 months to live, which is also, right, part of the objective criteria above the age of 18, less than 6 months to live, terminal illness for MAID, right? So instead of a big continuum, is it possible that medical assisted dying, medical assisted death, MAID, could it be swapped out and be a replacement for hospice? Could it be viewed as something saying, I don't even want to go to hospice, and my version as a patient relieving suffering means to terminate my life rather than waiting for hospice to determine whether or not my emotional, physical, mental, or other pains have been relieved. What do you guys think about that? That's my provocative point. Could people see it as an alternate path and say, instead of hospice, I'm not going to wait, I want to die now? And then do
I mean, the
we,
reality is that
as physicians,
90%
go with
of
that?
people, um, but if you look at the data, Emil, 90% of people who are prescribed MAID in the United States are on hospice. So they're not currently looking at it as a replacement for hospice. Could that happen in individual
Mhm.
cases? I'm sure that it could. But what you're talking about actually makes me worried about the slippery slope. Are we cracking open the door to where not people who would be eligible for hospice or ask for MAID in lieu of hospice? What if people who are not even eligible for our current definitions of hospice start thinking about that?
Mhm.
And that's what we're seeing in other countries. We'll talk about Canada and track 2 of medical assisted dying in Canada and some of the data from there. But to your point, that's a very real possibility as well.
Mhm.
I think that's really valid, Sean, because the reality is that patients, even when they do pursue the MAID option, oftentimes will have hospice support because this is not an instantaneous process. This is a process, on average, that can take within an hour, maybe sometimes 22, 26 hours, and there's possibility of even longer. Plus, there's a benefit of hospice of bereavement for families afterwards, because even after that death takes place, there's still fallout for the caregivers who are loving on this
Mhm.
person. And so, hospice also provides that bereavement support for families grieving after their loved one. So, I don't think
Mhm.
that MAID's ever going to be a replacement for hospice. But I do worry that MAID is going to be an extension of what's felt to be the scope of palliative care, that
Mhm.
all palliative care clinicians may be thought of to that this is within their scope and they need to be able to prescribe MAID. And I think
Mhm.
that there's definitely some challenges there for many of us who feel that, even though, I had people who, when I was pursuing palliative care and oncology, they said, "Oh, great. So you really love to watch folks die, don't you?" And I said, "No, I love to watch them live." And I have seen more life in somebody who had a cancer with a limited life expectancy. And I've
Mhm.
seen dynamic life in hospice care more than other people who may have never seen or experienced it. And I would say that that ability to future cast for
Mhm.
yourself to say, I know what my life's going to be like in hospice care and it's going to be bad is usually inaccurate. I
Joe, let's
think
go with that
that people,
future
when they
cast.
actually walk through it, is tough.
Yeah, yeah. Let's go with the future cast because I think my position on this topic is really like I'm trying to see both sides of the equation and still weighing. So I'm not firm on one side, but I love what you said about bereavement after the fact. But here's my qualm about this. Okay, is that after the fact for an irreversible action, which is the death of a loved one, bereavement support through hospice invaluable tool for the family, but what I worry about is that there might be discord or disunity within a family for something that already happened and you cannot take back. So the example I might give is that we know in genetics counseling, right? So people want to know is my cancer or illness hereditary, but they don't get the test by showing up to the visit. They get counseling first to say here are the potential implications if a gene is found that you might have inherited and may have caused your cancer, or the other people not yet with cancer in your family. What are the implications mentally? And some people decline cancer genetics testing, right? As a result. So I
Hmm.
would, I guess I'm asking slash advocating for bereavement, not after the fact, but counseling up front. I think for the family members
Mm.
saying, your family member has opted to go through with this, and legally and every other measure, as a patient who qualifies with terminal illness, they're on hospice, then fewer than 6 months to live, they qualify objectively. And maybe the counseling is with that member in the room without them, and to kind of maybe you call it pre-bereavement. I mean, what do you all think about that?
Mm.
I think that should be the case regardless, right? And I actually think that's what hospice does regardless, right? I
Mhm.
think that to your point about hospice and MAID, I absolutely agree. It shouldn't be one or the other because hospice is, I know hospice in theory is about end of life, but it's like it's about life at the end of life, right? And
Mhm.
so I think of it as like to your point, Joe, about everything that you were saying, where there's all these. It's not oh we're just doing symptom management. It's like the spouse is supported and the kids are supported, and it's like a whole community. And if you are pursuing medical aid in dying, you need that community. So whether
That's right.
it's whether it's through hospice or MAID now has a hospice exact infrastructure, right? Which I think would make no sense. I think those patients should just be on hospice, like logistically. I think that those are really important. But I think what I come back to when I'm thinking about all this is that, Joe, I think you had said most patients, obviously not all, but most patients do not pursue MAID because of pain, right? Because of like,
Hmm.
oh, we can't
Mhm.
figure out the titration of their opiates or whatever that is, right? And so I think I don't know that it's entirely it would make a whole lot of sense for patients to go on because they're suffering and their pain is not controlled or they're breathless or whatever it is that they
Mhm.
go to medical aid and dying. Like I just think that the patient population are two different things, right? If somebody is suffering with physical symptoms that can be palliated, or mental symptoms that also can be palliated, because it's not just drugs that we can palliate with, right? Obviously, I think that going through hospice is incredibly important because even though I'm pro MAID, because I think the services and the way, not just service, it's the care, it's the love that like these
Yes.
patients receive in hospice outside of just the bed in the house and all of those things are incredibly important to the process of MAID if that's where they decide to go. And so even though I think that they should have that option, I think going through hospice is incredibly important.
So I support you. I did want to explore one dimension, if I could, before we go into statistics, and that is the role of us as clinicians, because I don't think we've really talked about this aspect of MAID that like we all took oaths, primum non nocere, right? Like don't do any harm,
Mhm.
and the understanding too that we see, like one of the things that drives Shruti and I to social media, and I think you guys too, is the fact that there's mistrust of modern medicine, like
Mhm.
there was kind of this culture where people really trusted in medicine and the institution of medicine. And now I feel like that trust has been eroded. And does any of you feel that by prescribing harmful treatments that you know a patient will then take and harm themselves with, and that was the intention from the start, do you feel like that erodes some of the foundation of the public's trust, even if the patient was pursuing it, to wonder the next person that walks in your office, are you prescribing things to help them or to hurt them? Is that distinction blurred for any of you guys?
From
So I think that with like autonomy, with all the like, there's like non-maleficence, there's do no harm, right? There were all these things that we were taught in med school correctly, ethical principles, and all of them are not. They're not standalone principles. Some of them actually like compete with each other, and do no harm, of course, is one of them. But I would argue that when I prescribe somebody like who can be cured, let's say they have a stage 1 colon cancer, and I say I would recommend surgery so that you can be cured, and they say, you know what, I saw online that I want to take ivermectin. I feel like that is also harm that is being happen like to the patient. And so I guess I just feel like do no harm also means I have to convince my patient at any cost that they need to do this treatment so that they can survive. But that is in direct competing with the autonomy principle or pillar that we were taught. But I'm
Yes.
also supposed to say, you know what? I'm going to give you all the information that I possibly can, and I care about you, and so I'm going to tell you, but you are allowed to make decisions for yourself, because and I respect that, and I respect kind of how you came to that decision. And so I hear you what you're saying about do no harm, but if I were to prescribe aid in medical aid in dying, I don't feel like I'm going to the next patient, and I don't feel like those lines are blurred, because I think, well, I think in when we think about the ethical principles, I think there are blurred lines because the ethical principles themselves are in competition.
Mhm.
I think that's.
And I
Hmm.
think, Joe, people who are practicing MAID and for patients who may be asking for it, they don't feel that the process of medical aid in dying is harm. I think they interpret it as a net gain for the individual, even though I don't know if I should use the word irony, but the irony is that it would result in the participants dying. The philosophy is that it is still less harm than the alternative of that person with their specific situations. And I was wondering, and we didn't have a chance to talk about this at the beginning. I know you practice in a state that does not allow for MAID, but can you tell us, if let's suppose you're seeing a patient, you're that someone who's practicing in a state where it is allowed, and MAID is legally practiced, and the physician and their care team and the family and the patient come to an agreement that that is the best option. So they meet the criteria of being an adult with a terminal cancer, less than 6 months, being with no major, having decision making capacity, so no psychiatric, psychological condition. What's the process after that in the US? Because you kept mentioning that people take the medicine and don't take it. Can you walk us through what happens after someone's been prescribed MAID and what the process is in the US?
Yeah, so again, there's definitely some variation state by state, but in general, usually it's not just one request. It has to be at least two requests. They have to be separated by, I think, at least 15 days in most states.
Mhm.
It has to be attested that this is truly a terminal diagnosis, not just by one doc, but multiple docs, usually the attending physician and a consulting physician. There has to be that sit down kind of pre counseling, like Emil was talking
Mhm.
about, where they actually kind of go through, hey, is there some other reversible things that are playing a role here, like depression that could be treatable?
Right.
Do we need a psychiatrist's involvement to make sure that they're evaluated? Though oftentimes in these states, when they report on this, less than 5% of patients are actually referred in those
Mhm.
situations. And usually there's at least a 48-hour waiting period. I think California has a additional final attestation form
Mhm.
right before they plan on ingesting. So you can prescribe it, but before they can actually ingest it legally, then they have to give that final attestation in that 48 hours. And there's no third party that can administer it, not a
Mhm.
loved one, not a caregiver, or any medical professional.
Right. Not for administering,
And
but
so,
there are, my understanding is also, in addition to everything you just said, the two witnesses, right? If I'm not mistaken, I mean, it's more of a like legal aspect,
correct.
but two
Yep, two
witnesses.
witnesses.
And I think the way it's worded, it basically states two people who are witnesses that may or may not be able to be family, blood relatives, but people who do not stand to benefit from the death. So in other words, they're not like in the will and would financially gain, right, from the death of this
That's
person
right.
that might have a motivation to have someone not live anymore and to gain their material gains. So um, there's definitely legal, and I think some of the political ramifications. So you're in a state that doesn't have it. I'm in Minnesota, and in Minnesota has, I guess, in the Midwest, or at least the Upper Midwest, has tended to be, at least large pockets of more liberal nature than other parts of the Midwest. But it seems to have really, in a way, like many things, unfortunately, kind of have a political divisiveness. Like a lot of red states are firmly against it, and some of the states that are blue in the political sense have adopted it. But what is the current momentum is building in mid 2026 towards more than the third of the states that, as you said, Shalon, at the outset, that are participating in this or have considered this?
Shalon, I don't know if you have those up-to-date statistics, because I know you were going to bring some. I can grab some if you don't.
I mean, you could speak. I mean, it's just off the edited
I,
record.
I know
You
from
could
what
speak in
I
more
have
abstract
heard
terms
that
if you
we're
want.
seeing more and more. I think Illinois just got theirs through. New York, I think,
Mhm.
also just got an approval recently.
Yeah.
Maryland, I think, just missed by a vote, but DC is already
Mhm.
had some legal language surrounding this. So we are seeing an increase in prevalence
Right.
over the last few years. And so I do think that this is something that is going to impact a significant amount of physicians. And I've been seeing it be a major topic at every palliative care conference over the last 3 years
Right.
because I do think people are experiencing it more. And some of the individuals that I know that do prescribe for MAID in states where it is legal do have palliative care background and are doing it for their own continuity patients.
Oh, I'm just gonna say that I think it's probably also, I think, really hard when it's being rolled out state by state, to have like a kind of a unified process on how to do this. Like, I know it's legal in California, but I don't know how to do, like, I don't, beyond that, I don't know, right? And if I had a patient to ask me, I
Mhm.
of course would find out and I would figure it out. But it is so interesting because, we're talking about it. It's a big issue for obviously our patients. Obviously, not a lot of patients even request it, but because I think it's being rolled out also state by state, there's, I think, a lot of lag in terms of like the uptake and figuring out kind of a very streamlined process on how to do this, you know?
Mm.
And I think that's actually an important point because even though two-thirds of the US population lives in a state which may have access to MAID, less than 1% of deaths are in the United States are taking place on MAID. But when you look at Canada, that number is closer to 5%. And when you look at people who are
Mhm.
older, that number can be in double digits. So double digit number of older Canadians are dying while being enrolled on MAID. And Canada is distinct from the US, and they have two different tracks. You have track number one, which is pretty similar to what we've been describing in the US, but you have track number two, where you don't need to have a terminal diagnosis. And a lot of individuals who are pursuing MAID with track two have chronic conditions like an autoimmune condition. They could have frailty, diabetes, and a lot of the symptoms that they're having are around functionality, not wanting to feel like a burden, not necessarily pain or impending organ failure. And I'm wondering and maybe Shruti, you can go first on this one. When we talk about autonomy and we talk about someone's perspective, um, where do you think that where do you think that that society should draw a line? And is this just the natural evolution that we're seeing in thinking of Western societies? Yep.
I think it's really easy to talk about all the ethics of all this when we're not the ones suffering.
Mm.
That's my take,
Mm.
right? Of course, if we lived in a world where someone who was struggling with uh, diabetic nephropathy and had to go to dialysis, was able to have somebody maybe help them get access to meals because they get really tired right after dialysis, right? I'm thinking of just examples of people in their day to day. Having a chronic medical condition is extremely difficult. We deal with this all the time where patients are deciding
Mhm.
between their nausea pills and groceries or their mortgage and they're like paying for parking or can't make your appointment. Why did they no show? No show because they couldn't pay for the Uber, right? Or like there's a million things like that, right? And so I think it's really I think you can't talk about the ethics. Do I think it's good in Canada that some double digit percent of people are like, I can't deal with life as it is on this earth because I am suffering in some shape or form when they have a chronic condition? No, that's horrific. That's
Mhm.
horrific. But unless we're talking about how to make those, like, improve those people's lives in whatever way, whether it's functionality, support, aid, getting people medical aid. Like my parents' generation is constantly talking about what is it going to look like in the next 10 years? Like, how are we going to afford medical care, right? What if something happens? These are like at the family friend parties, right? All the uncles, aunties, they're trying to figure out, like, are we going to go back to India? Are we going to, right? That should not be
Yeah.
the plan. That
Mm.
Right.
should not be the
Right.
exit strategy, right? And so, anyway, sorry, I get riled up about this because I love my parents a
I
lot.
love this.
Very
No,
No,
well
I'm
this
said.
glad you
really
brought it
speaks
up.
to
I'm
your
glad you
heart
Very
brought
and
it
well
your
up.
said.
passion.
Yes, yes. The cultural understanding
Honestly,
part.
I just feel like, yes, is it horrible to to circle back to your question? Is it horrible that many people feel like they need to go towards a MAID type option? Absolutely. That is a bigger societal issue. It's not really a black or white, do I feel like that's okay or not
Right. Right. No,
necessarily.
I think bringing it societally. I'm really glad you brought up cultural understanding because we all either, we talk about the United States, because we're here, and Canada is, close enough to the United States, but both are very heterogeneous countries, right? In our own communities, pockets of people from around the world, and we obviously know, and we come from a lot of us, we all kind of come from kind of culturally different backgrounds that any physician assisted suicide made any variation of that is going to be viewed with abhorrence, right? In some cultures, let's be honest
mm,
with that, including cultures that have well entrenched in the United States, in the communities we are treating, and even maybe in our own personal backgrounds. And so that variation, to the point where even people might say, well, I'm not sure that's going to be the solution for me, to the point where I might have to leave the United States, that people might be saying that is the other side of the coin. And the societal impacts of that, I guess I don't want to go down a conspiracy theory road, but if whether insurance companies, whether society says it's cheaper, quite frankly, if we talk about financial toxicity, it is cheaper for people to encourage people to take the MAID route so we don't have to pay for their healthcare and all the other things that go with alleviating their suffering. And I just worry is objectively that it might be seen as the only route or a cheaper route, or I think in the era of this so-called sandwich generation, where people, in the middle age, you have to take care of the generation below you, the children of a certain age or certain needs, and then the parental generation that's getting older and more infirm, where the older generation might say, I don't want to be a burden to of any culture. I don't want to be a burden to my children, and therefore this might be the route I would take to alleviate my children and the generations that come after. Just some
So
thoughts.
and
let me throw some numbers at you about what we know about the use of MAID in the US and Canada, and then you all could tell me what surprises you about those numbers and kind of what take home message it can give for our listeners. So more than
Mm,
50% of people who enroll on MAID in the US are college educated. Over 90% of MAID users in both US and Canada are white. Less than half a percent of users in the US are black.
mm,
39% of Americans who received a MAID prescription never used it. They just wanted to know that the option
okay.
existed.
Oh.
And on track number two that we talked about in Canada, the factors that were contributing to someone looking to enroll onto MAID was loss of dignity, emotional distress, isolation, and loneliness. So, which of these numbers do you think appeals to you in terms of our understanding of how MAID is being implemented in North America?
I think to me, the isolation and loneliness piece is the most heartbreaking of all of this because to me, as an oncologist and as a palliative care specialist, what breaks my heart is not seeing a patient with advanced cancer. It's seeing a patient who has absolutely no support at
Mm.
home. And I know that the nuances of culture, social determinants of health are so complex. We're not going to solve it in this podcast. But I will say that the way that we spend money in oncology is so focused on treatment and very little is spent on support. And I
Mm.
think to me, this is a call to action as a palliative care clinician that our field oftentimes gets so focused on physical symptoms. We're managing opioids, we're managing complex physical challenges, when in reality, going back to that sense of meaning, how are we being more creative in exploring how to with a patient with a terminal illness who may have physical limitations, how can we partner with them to be able to create an experience where they're able to have an alleviation of their suffering, regardless of what they're going through? I mean, I love some
Mhm.
of the research that's going on right now with psilocybin and psychology marked meaning journeys. It's a spiritual experience for patients. Even VR therapy, where we can take somebody who's totally immobile and let's take them to Italy, let's take them to Spain, let's take them to places that they wouldn't be able to go to and experiencing meaning. And then how do we create connection? We're
Mm.
in an isolated society. How are we being able to reach out and have that human touch and connection in an era of social media and AI? I would love that human touch to be restored to medicine again.
So 39% who explored it, they tested the waters and then opted not. That, I mean, if you had asked me to guess, I would have said under 10%. But 39%, so
I
greater
think
than a
it's
third, say yes, but I will not enact it. I just want to know it was there. It was comforting to know I have the option. I don't know what percent of the 39% within 6 months or within a few months or within a few weeks opted to go forward with it after changing their mind. But that's extraordinarily high to me. What do we make of that?
I think this is like our modern culture. I think, when you look, one of the great books, Atul Gawande, Being Mortal, about a third is talking about palliative care and dying in America, and about two-thirds is growing old in America. But just
Mm.
how we have taken multi-generation households, which is how most of us live and how some cultures still do, and we've now created institutions where now people are dying in hospitals and nursing homes, but they're not dying in home. And now death becomes something that's shoved away in a dark corner, but the reality of death is messy, it's inconvenient, it's challenging, and we want to schedule it. We want to have control even of death. And so I think instead of pushing death away and scheduling death, I want us to allow death to slow us down, to be able to help us breathe and see something bigger than ourselves. We still have 100% mortality with all of our great trials, all the ASCO plenaries, 100% mortality in the US in all comers. Let's explore death and embrace it. Let's bring it back into our culture again. And I think if we look in death in beautiful ways, and you can see this across cultures, I think we're not going to have the same aversion and the same need for control. I think we're going to be able to surrender that control.
I think to your point about the control, it's something that just like I'm going to loop back to something we've talked about. All of us have talked about so much with cancer risk. I feel like a lot of people are kind of fixating on. We know that there's a rise in early onset colorectal cancer, and everyone's fixing on diet, exercise, and essentially things that are controllable factors. And because the alternative is uncomfortable, that we don't know, and it might be something outside of your control. No one likes that. And so to your point about death, it's like it's across, like we want control. I want control. Like I totally get it. And so To your point about that, I completely agree. And then the other point that I want to make is the thing that we were talking about with the loneliness. You know, a lot of my friends are having kids now, and we're looking at how, and we think back to when we were all growing up, and we grew up with like 10 families in like maybe like a 3 block radius. All of our parents, they met in their like apartment complex, and they all moved to like a 3 block radius. They all had kids within like 1 to 2 years of each other, and they're my family, right? Like when I say my family lives in the Bay Area, it's them. And so their kids are my nieces, right? Like that's just how it was. And when my mom had to go to the store, she could drop the kid off at someone else because there was already like 2 kids there, and like you know, and life was a lot harder, obviously, because like they didn't have certain things, but easier in certain ways because they had community. And now, when I look at some of my friends who have kids, right, their closest friends with kids are maybe 30 minutes away, right? We live in the Bay Area. It's not that easy to buy a house like within like a 2 block radius of your friends. And that loss of community then extends. And so, my concern, I bring that story up to say, my concern is that that loneliness is going to get worse, right? We're saying, like, this is loneliness for people of like our elder generation, but our generation is eventually going to get there, and we have a loneliness epidemic within you know, all ages, I would say. And so I really do worry about kind of some of those things, because loneliness, you know, is something that I feel like is something we as a society can fix. A lot of these things I truly believe we as a society can fix, right? That double digit Canada percentage, I think we as a society could fix. But it would take, you know, the mother of all, like just lifts, you know, to fix those things. And then the other thing I just wanted to, those stats, I was surprised that 90%, the demographic, 90% were Caucasian, I think you said, right? That is surprising to me. I don't really have a good explanation for it, but I kind of thought that it would be, yeah, I kind of thought it would be like everyone's interest.
Here's another
I'll
thing
say,
that we haven't talked about for MAID, because insurance doesn't cover it. It's cash only. So it's you want to die, you're
okay.
going to have to pay through the nose. It's all private
Wow.
pay.
How much is
Wow.
And
it?
it
Okay.
is expensive. I
So
don't
that's
have numbers,
substantial.
Sean. I don't know if you looked up, but it is expensive
Guys, live,
to
I
to
gotta
Wow.
get
look it up.
MAID. And so
Yeah.
it could very well be it's college white because they have the funds to get it. So it's access and
Yeah.
equity all over again.
It always is, right? A health equity. But I'll say, Shruti, I was not surprised to hear the 90%. I mean, I was only surprised to hear it's not 95%. Because I think just cultural, I mean, the history, right? Centuries, not just decades, but centuries of mistrust of the medical system. And I think this is just an extension of everything else about, you know, so this is like the permanent fix, right? This is not like, oh, I'm going to be given a medication, and I'm not certain that this is the right person giving the right thing for the right condition. Do I even have this health condition? This is the ultimate end. It's death. And so I would not be surprised if, I'm not sure if there are studies, but we can certainly follow up on that show mistrust in the medical system extending to MAID
Hmm.
being considered the ultimate solution. And
Part
if
of
it's being offered, having a suspicion about why are you hastening my death? You are trying to
yeah.
get rid of me and not treat me. That's a counterpoint that I think of.
Yeah. So I
So
just looked it up. It looks like the drug itself is around like 800 to 1,000, and that's not counting all the medical consultations. That's
Right,
not
right.
cheap. Okay.
Wow. That's not.
Wow. I didn't know it wasn't covered by insurance, so that's actually really interesting to
Mm.
know.
So this has been a fascinating discussion. Again, thank you very much, Dr. Joseph McCollum, for joining Only Oncologists in the building for a fascinating discussion on MAID. That's all the time we have for today, and thanks everyone for joining.